Dr. Hashmi, thank you again for that overview of myeloma. Just a quick question as a treating myeloma physician, a lot of our patient panel tends to be typically patients with precursor diseases, right? And I'm sure that a lot of questions that you keep getting are, what can I do about it? This is really torture being stuck in limbo. Is there anything I can do? And my question specifically to you is, for those patients who are in smoldering myeloma, who we think are on the verge of really, converting, how have you structured your practice? We have a lot of data coming in which, potentially we can treat high risk smoldering myeloma, etc. But how do you go about it? Are you worried that you're using up some of the agents earlier, inducing therefore resistance to that in what would be typically frontline myeloma? Or just for the audience, how would you go about treating high risk smoldering myeloma specifically? Because that's a question I'm sure which is uppermost on a lot of patients' minds.
Yeah, I think it's a very relevant question, and thanks for asking. When we look at smoldering myeloma, there are at least three different models that we can utilize to stratify that into three subgroups. Low risk smoldering myeloma, where the risk of progression to symptomatic myeloma is very low and observation is very appropriate. Intermediate risk smoldering myeloma, where again the risk of progression is a little bit higher than the low risk, but lower than the high risk, where observation is actually what many physicians and practices in US would do. When the question comes to high-risk myeloma, and different models that have looked at it, looking at the protein levels, the light chain levels, the amount of cancer in the bone marrow, I think one of the very first thing that I always do is to, first of all, confirm that it's not already myeloma. I do bone marrow biopsies, PET scans, and MRIs. And once I've confirmed that it is smoldering and it's high risk, I actually discuss it with my patients because there are certain trials that have shown some benefit of treatment in the form of chemotherapy, oral chemotherapy for a 2-year duration, where they may slow down the progression of the smoldering myeloma to symptomatic myeloma, but not necessarily make these patients live longer. Chemotherapy does come in with some side effects, and those side effects can actually impact the quality of life. I have a robust discussion with my patient, and if they are actually inclined towards having treatment for a high risk smoldering myeloma situation, I would consider oral chemotherapy options for them. Before I do that, also look into our clinical trial portfolio. Being a major academic center, we have many different clinical trials that are evaluating therapies for patients. And again, if patients have the ability, the desire, the determination to pursue a trial, that will actually be something that I highly encourage all of my patients. Besides, clinical trial, regular therapy, observation, in my opinion, is what I tend to favor, and many of my patients also agree with it, with a very clear plan to follow it very closely. I'm actually doing blood work sometimes every 3 months. There are patients that actually do blood work every month to capture any smoldering from becoming a myeloma in a timely fashion. And I also do scans in these patients periodically, at least once a year. So all of these options I discuss with my patients, and we make a decision in consensus whether they want to go for a trial, whether they want to have some oral chemotherapy options, or they want to actually just observe, but observe very closely. So these are the things we look into.
No, wonderful. Thank you. That reflects a lot of our practice as well, but that keeps getting, second opinion consultations, etc., when they hear the same opinions from other doctors as well. So thank you for clarifying that.